Welcome to the Personality Couch podcast, where we discuss all things personality and clinical practice. I'm your host, Doc Bach, and I'm here with my co-host, Doc Fish. We are both licensed clinical psychologists in private practice, and today we will be continuing our borderline personality disorder series. So we have talked a lot about the symptoms of borderline personality disorder, or BPD, what it looks like, and the deep pain that these individuals experience. But it's also important to talk about what professional help looks like for this condition. So let's dive in. We have learned so far that personality disorders are lifelong and pervasive. So where does that leave treatment for borderline personality disorder? Is it treatable? Is it always treatable? What is your take, Doc Fish?
The answer is going to be complex. It's treatable, but like most disorders, illnesses, or even injuries, sometimes there's not a cure. So for example, if you break your leg, it heals, but the pain might flare up sometimes when it rains or if you start running. Or a different example, for type 2 diabetes, severity might change. If your sugar levels fluctuate, if variables line up, you can go back to like safer levels, just like borderline personality disorder. You can go back to safer levels. It's going to fluctuate.
Sure. That makes sense. Yeah. And if I'm not mistaken, as we age, symptoms often decline, at least in regard to impulsivity with borderline. Is that correct?
Yeah. So symptoms can remit. Impulsivity is going to be the quickest to do so. Any mood symptoms are going to be slower to go away.
Sure.
Now, in contrast, recovery is harder. So symptoms can fluctuate, go up and down. Recovery is harder because everything fluctuates and is unstable. Recovery can also be hindered by external things like that are reinforcing. So if you're reinforced by remaining sick, if it keeps an attachment because you're sick, that's reinforcing. Or if you hold your diagnosis as an identity, if you get rid of that diagnosis, like that's painful. So it's reinforcing to keep it. So that's also going to be something that might hinder recovery.
Sure. And sometimes these are like unconscious or subconscious things that are keeping us sick or keeping us from getting better. It's not always a conscious, like secondary gain, but sometimes these reinforcers in our life, especially with borderline attachment or relationships, can be a big part of those reinforcers where I'm afraid to get better because of potentially losing a relationship or it disrupting a relationship. It makes sense. This is a tricky, non-linear approach to treatment. Like it's not a one size fits all.
Yeah, it rarely is. Yeah. Okay. So Doc Bach, what are other factors to consider in treatability?
Yeah. Well, there's a couple things that I think of, and that's the first one is like wanting to get better. So similar to what you just said, like if there's other reinforcing factors, and sometimes it's subconscious, sometimes it's not, but like, does the patient actually want to get better? Or are they just here to check a box? They're here because it's what they're supposed to do. They're here because a loved one or friend kind of pushed them into treatment. We can't force people to get better. They have to want to. Like the old saying, you can lead a horse to water, but you can't make it drink. The same type of thing with treatment. Like someone has to want to take that drink. They need to want to feel better, to get better. But one of the major hindering factors, I think, of health and wholeness and just wellness is insight. When we don't want to go to those deep places, those uncomfortable places of self-awareness and understanding maybe our motivations or what's behind the scenes, what's going on under the surface, we're not willing to be self-aware of all those layers, then that's going to be a major hurdle to treatment because we can't address a problem if we don't know that the problem exists.
Or if you don't want to face that the problem exists. Yes.
Exactly. And sometimes that problem is deep inside ourselves.
Yeah, that makes me think of APA actually has a term in their dictionary called the aha experience.
Ooh.
or the aha moment. And so that made me think of like insight. Insight is when there's like reflection and you dig deep enough to have that light bulb moment of like, oh, I get it. I'm facing this. This exists. And so what you're saying is like, if we are avoiding those moments,
Yeah,
that can hinder treatment.
sure. And it's not uncommon because it's hard to look inward. It's hard to look at ourselves and look at what we're bringing to the table, how we're contributing to the distress that we're in. Now, that's not to say that it's all our fault, but we have the power to make changes inside of ourselves. So we have to be willing to have those aha moments and to look at the uncomfy things.
Right. And then you also touched on like not being motivated for treatment.
Oh, sure. Sure. So, like the lack of motivation, like I said before, you can't force someone to go to treatment. Like, you can't force them to get better. Like, maybe you can get them in the door, but the actual treatment of a condition, the person has to want to get better. And the thing with BPD is that they're in such great distress and such great pain. They're often willing to step foot in the door. So, that's the great first step. That's step number one. Awesome. We're there. But that can't be the only step. And I like to think of this in a similar way to like, going to the gym, or like, let's say that you have like fitness or weight loss goals. Just walking into the gym isn't going to meet those goals.
Unfortunately.
Right? There's no magic door that you can walk through. There's no magic therapy door. We don't come with magic wands. Like, you have to put in the work. So just like when you are going to the gym for whatever reason, like, you have to make lifestyle changes outside of just showing up at the gym. Showing up is the first part. It's important, but it's not the only part. So when we have people who are just checking that box, but not willing to put in the effort for whatever reason, there can be all kinds of different reasons for that, all kinds of internal blocks or things that maybe we're not willing to face yet, or we're just trying to dip our toe in the water and just not go to those like hidden, maybe ugly places. Right. So we can't force motivation. And if someone is not motivated and they're just coming in to check a box, let off some steam because they're in pain and they just want to, hey, I had a rough week, I want to vent. Yeah, that's probably not going to have as positive of outcomes as someone who's willing to put in the work and make the changes.
That makes a lot of sense.
Yeah. What about motivated people? Like, what does that look like in treatment in your experience?
Yeah. So when there's high motivation, I think, well, first we also have to consider like the severity.
Yes.
So even if you're motivated, if you are oceans deep in a disorder level versus like only having a toe in, like you're just over the line, you can make a ton of progress and still stay in that disorder level.
Yeah.
Now, disorder level means like there's going to be impairment in life across settings. There's going to be instability across the board. So you can have different outcomes putting in the same amount of effort as someone. So I don't want motivated people to ever think like that they're failing just because they're still having that impairment. Like you can make a great movement and great progress and still have more to go.
Sure.
But we all have personality. So we're going to likely have the same structure. It's just we don't have to live in that disorder space. External factors like stress, traumas, support, or lack thereof, that can influence where you're at as far as like the health continuum. But I think just in general, for that motivated person who is in touch with their pain, who wants to get better, who wants to put in the work, they're gonna see improvement in their symptoms.
Sure. And going back to what you said earlier about kind of what I like to think of like a recovery mindset. So we all have personality structures, right? That structure isn't really going to change too much over the course of our life. Like maybe if there's like a major traumatic event or a major enlightening moment or something. But generally speaking, we're going to be at least the same structure. It may not be at disorder level. So just like someone who is a recovering from alcoholism or recovering from some addiction, like there's always a need to watch, like to be careful, to be on guard, because that's the personality, that's the structure to go back to that addiction. So living in recovery. And I think in a similar way with any of the personality disorders, but especially BPD, because that's what we're talking about today, is knowing that you're probably always going to have those tendencies towards the impulsivity, towards maybe the self-harm thoughts, or, the push-pull in relationships. Like that internal pull is going to be there for those things because the structure is there. So that's not just going to go away, but there's coping skills to help quell those symptoms and decrease those symptoms and make them more manageable so that life doesn't feel so rocky and so unstable itself. Yeah, living in this recovery mode, but using those coping skills, I think is really, really important.
Yeah, I love that example because every personality is going to have areas of strengths and their areas of weakness. And you're going to have to know and be aware and watch out for those weakness areas.
Yeah, for sure.
So borderline personality disorder is treatable. We got that.
Yep.
But how do you know like which treatment to search for? Do all of them work? Yeah, tell me about that.
Yeah. So that can be confusing, right? Because in psychotherapy and in any sort of counseling, we have like the alphabet soup of acronyms of different types of treatment. And it's like, well, where do I go? Like, where do I even start to look for treatment? So not all treatment is the same, but I will say, alphabet soup aside, the therapeutic relationship is the number one predictor of therapeutic success. So what that means is that relationship with your therapist, if it's positive, if you feel like there's an appropriate professional connection there, you feel like your therapist is in your corner, it's just a good fit all the way around. That above the alphabet soup is going to be a better predictor of therapeutic outcomes. So that's number one, before we even get to the different types. Number one. So the gold standard for treatment is dialectical behavior therapy, or DBT, which was created by Marsha Linehan, who also struggled with borderline personality disorder herself, and came up with a very specific protocol for borderline and for the treatment of borderline. And that is what we call kind of the gold standard of treatment for BPD. Now, there are others. There's other types of treatment too that can be helpful. And we're not going to list off all of those today, but that's kind of the one that most people think about with regard to treatment.
Right. And then I think there's also different types of DBT. So there's like strict DBT, which has like individual therapy, group therapy every week, and like a crisis call setup. They're usually like 6 months to a year programs. And then there's like DBT informed treatment. And that's like pulling from the DBT. I
think I would probably fall more in the camp of like a dabbler, like not the purist with, the 6-month, 12-month program. That certainly can be helpful, but kind of pulling from different tool belts, different alphabet soups that are in my toolbox, typically when I treat. But kind of moving away from that. So what we know is that borderline is the most likely to seek treatment, right? We've talked about that pretty extensively. And being that we are providers, there is a pretty good chance that we have seen BPD in our practice. So Doc-Fish, I'm curious what it looks like for you to treat borderline personality disorder, and what do you focus on in sessions?
Goodness. Okay. See, the trouble here is that BPD is always changing. It's ever shifting. Every individual is different.
Yeah.
Treatment is individualized because there's no two borderline persons that are alike. So it's more helpful for us to talk about broad themes and specifically invisible concepts in therapy.
Ooh, invisible
Yes.
concepts.
Yeah, they're tricky, but they play a huge role in opportunities for growth.
Yes.
Let's start with boundaries. Boundaries can be spoken or visible, but most of the time they're unspoken and invisible. But regardless, they span the entire therapeutic process. Boundaries are extra important for personality disorders in general, but I think especially important for borderline personality disorder.
Yeah.
If it wasn't invisible, I would think I would liken boundaries to being like the frame of the therapy puzzle. Because when you put a puzzle together, I think most people put the edges first.
Oh,
and
yeah.
you use that to contain all the other pieces. Because without the frame, it's hard to find form. And you might not even notice like missing pieces or pieces on the floor that aren't contained. Yeah. But what comes to mind with boundaries for you?
Yeah, I love what you said about the puzzle. I'm a big puzzler myself, and that's so true. Like putting in the edge pieces helps give you context. Like how big is the puzzle going to be? Where is this really colorful patch going to go? Like same is true for treatment as well. It gives you the framework, the boundaries. And I think within that, one of the things that I always talk about is like your paperwork, procedural, policy stuff at the very beginning. So paperwork, payment, communication, procedures, all of that. There's no special cases. Like everyone has to follow the same protocol to enter treatment. And that means all paperwork must be completed before scheduling at our practice. There's no exceptions to that. No exceptions to that rule. Payment must be made the day of session. Like patients aren't allowed to just accrue a balance, accrue a debt at our practice. All communication goes through the front desk, and communication is for scheduling and payment and insurance only. Like clinical information should not be shared over email or phone, that needs to be reserved for sessions. Yeah, this really sets up therapy as a professional service and not just a chat or a chat with a friend or a stranger, however you want to think of it. It's really important to set these boundaries and the framework from the outset of treatment, just like that puzzle, right? Like this is the framework in which treatment, the context in which treatment is provided, and it's professional. It's a professional service.
Yeah, so that's kind of like the observable pieces. Are there any other pieces that you would throw in the boundary category?
Sure. There's a few more. These are probably still in kind of the observable camp, and it still has to do with policies and procedures. As a practice owner, I'm always thinking about that because it's so helpful for all conditions, but especially personality disorders. And with borderline, they really need those firm boundaries. But with attendance, I think you actually have a phrase with attendance about showing up. What is it that you tell patients?
Always tell patients the days that you don't want to come to therapy are the days where you probably need to.
Yes.
Even if it's just to sit in silence, something's happening, there's some kind of resistance, so it's meaningful to come.
And there's consequences when you don't come. That with the policies, if you're not going to show up, there's a fee. Like we've set aside our professional time for this hour for you. And if you're not going to show up, then there's most likely going to be a charge. And if there's a pattern of not showing up, then, I mean, potentially that's grounds for termination if, you're not showing up to treatment. And certainly if you're accruing a balance, we don't allow patients to accrue a debt. Those things can be really, really important in just establishing the professional relationship, as I said before. A couple other things that I think of like in the actual sessions are going to be, we can talk about anything, but you can't necessarily act on it.
Yes.
Right. And we can talk about how angry you are, but I won't tolerate like disrespect towards me. Like we can talk about how you're feeling. We can talk about that you feel angry towards me, but if you're up in my face being hostile, that's unacceptable. If you're destroying things in my office, That's not acceptable.
Sure.
And I think you have a phrase for that too, Doc Fish.
Yeah. Yeah, it's similar, right? Like we can talk about anything. You can be angry with me. You can yell at me. Can't knock over the lamp.
Right.
So you can't be destructive in the anger and behave on it.
Mm-hmm.
But let's talk about anger. You want to yell? Let's talk about it. Is it helpful? Because I'm not reacting to your yelling.
Sure.
It's probably not helpful.
I think the last thing in treatment that's maybe more overt is like, I'm not doing the work for you. And what I mean by that is I'm not going to work harder than the patient is working. And that can be hard because certain personality structures can really pull for us to do more than we're supposed to do. And as I'm talking about this, maybe this is more of an unspoken dynamic that's not as overt.
Sure.
But if we're spending more time outside of sessions, like preparing for the session, thinking about what we're going to talk about in session, if we're spending more time than the patient on those things, it's time to reevaluate. Like who's actually putting in the effort? We can't compensate if there's a lack of motivation, just like we talked about at the beginning.
Right.
Like we can't fill up or make up for that lack of motivation to get better.
You also mentioned earlier that the therapeutic relationship is the most important factor.
Absolutely.
I think attachment is a huge one. So attachment is the relational connection or avoidance between client and therapist. Now, in BPD, there's often a quick attachment, which kind of stems from that pain, that need for help or a helper, and therefore that need for relationship. And also with BPD, there tends to be like a push-pull of idealization or devaluation. So idealization is when the therapist is like the hero, the rescuer, best thing ever. Providers have to be careful because that feels good to hear. We can accept it, but not reinforce it.
Exactly.
Devaluation is kind of the opposite. It's where the therapist is viewed as the villain, persecutor, worst thing ever.
Been there.
Yep. It's less common, still possible. And it can even be fleeting. Like they can have moments where it happens. But it's the same thing. Accept it, but don't reinforce it.
That can be challenging.
It's hard.
And I can see how, we're using kind of villain, persecutor, rescuer. Like I'm seeing how the drama triangle might come into play with some of these personality disorders and with attachment in particular. Yeah. And I'm also just thinking of like the interaction between boundaries and attachment. So like you're saying, like, you're not going to react. Don't reinforce it. That's a boundary. We're talking about attachment, but it's a boundary. I'm not going to reinforce that. And I'm just thinking about like bad therapy is often boundary violations. It's often violations with the attachment relationship. And I'm curious, we're taking a little side tangent, but I'm curious if you have seen that, like kind of violations of the attachment or boundaries in the therapeutic relationship.
Yes, unfortunately, my absolute biggest pet peeve is when the therapist has too much self-disclosure. You do not want to know who your therapist is dating, what they had for breakfast, their own diagnoses. Therapy is the client's space. It's not the therapist's space. Client space. Client space.
Oh, gosh.
So that's my biggest pet peeve. I'm super passionate about that. But there's other things too. I've heard of some providers socializing with their clients outside of therapy because after so much time, they're friends. Not okay. It's just not okay. What about you? Have you heard anything?
Oh gosh, I have not been fully insulated from that either. But yeah, I had a situation where I was seeking therapy and it was a new appointment, and the therapist wanted to exchange business cards with me once I shared what my profession was. And so like we can't hold that this is like a therapeutic space. Like now this is a marketing meeting. You just switched that.
Oh no.
Yeah. So that's just a personal example. And then I think as a testing psychologist, I work with other providers in a different capacity. So Usually, if the therapist is the one that's kind of encouraging the patient to get tested, then I'm going to be talking with a therapist, trying to understand what's going on in treatment, having a very collaborative relationship with therapists in our area. And out of that, I've definitely seen a lot of dynamics that are concerning. And I hate to say a lot of dynamics because most therapists are good enough. However, we can get tangled up, especially if there's personality pathology, being that that's what we often treat at our practice. We're going to probably see more of that. And sometimes therapists can be blindsided or get tangled up in it. That can be like getting too involved in the patient's story and wanting the testing psychologist to rescue. I need this diagnosis to fix, to rescue something or someone. Or then on a different plane is the clients maybe wanting the therapist to meet all their needs and kind of getting wrapped up in that. Like, tell me what to do. Fill me up. I need to know constantly. And then sometimes that can get like passed through to the testing psychologist too. Like, well, you need to do this. It's like, did you get that from the patient? Are we holding those boundaries? Sure. Being possessive or controlling, like the therapist being possessive or controlling when it's time to end therapy, or perhaps they're outside of their competency and it's time to end, but they can't break the attachment because of their issues.
Yikes.
Yes.
That's not a good one. Yeah.
And probably the most severe kind of in the camp of attachment and boundary breaks is going to be like physical contact or intimate relationships with patients outside of session, or it just no. Don't do that. Don't do that. This is grounds to find a new therapist. If that's happening, find a new therapist.
So in the boundaries, I'm going to contain us and take us back to invisible concepts that happen in therapy.
Yes.
So we were talking about attachment. Part of the attachment relationship in therapy is what's like called transference, and then also counter-transference.
Yeah.
So let me explain. Transference is when, because the client doesn't have a full picture of who you are, they unconsciously perceive you to be in a role that they're already familiar with, that they already have a mental map for. For like example, like their mother. Okay. So then counter-transference is on the therapist's end. It's the therapist's own reaction to that transference, which often is going to mirror whatever that proposed figure is. So like whatever the mom felt, that might be what the therapist feels as well. So like it could be frustration or rescuing. So if you had a critical mother as a client, you might come in, you don't know who your therapist is. Like you have to learn all those dynamics. You don't know what their favorite color is, what they eat for breakfast, because you shouldn't. Okay. So if you had a critical mother, you're going to go into therapy and you might think like the therapist is going to judge you, or therapist is going to be critical, and you might act defensively or in a passive over compliant manner. And whatever that reaction is, that's going to trigger the therapist's own reaction, that counter-transference.
Wow.
To most likely react like mom did.
Wow.
Does that make sense?
It does. There's so much more that goes on in therapy versus just active listening. Like we each have these kind of like maps from childhood, and they guide us in relationships. They guide us in attachments. So there is so much more that goes on in the therapy relationship versus just active listening. There's so many dynamics, not just that the patient is bringing in, but that the therapist is bringing in. And that's why we've got to know ourselves and contain ourselves and be boundaried so that we can just work on the client stuff, the client's maps from childhood, not our own. Let's not bring our own stuff into that, because it just gets way too messy if we're just triggering each other and we're not really engaging in treatment. But those unspoken dynamics and those kind of like attachment maps, that informs a lot of treatment.
And I think one of the most important things, in my opinion, for those maps, like you're probably going to therapy because those maps aren't helpful.
Exactly.
The maps you learned are no longer working. And so we have to find different paths. And corrective experiences is something that I find super valuable. Invisible though, too.
Okay.
It's hard to explain because it has to be really individualized. So, for example, if you have somebody who turns anger towards themselves, so instead of being angry with someone else, they're like, I'm bad, I'm not good enough, I'm fill in the blank. Whenever they are able to express anger for someone else, or like even admit that they're angry for someone else, that might need to be celebrated.
Sure.
Because it's different than what was on the map. But in contrast, if you have someone who is outwardly destructive in anger, you're not going to want to celebrate that for them. You're going to want to celebrate like taking accountability or self-containment for their anger. Another good example of this is if someone has been parentified, so in childhood being forced to take the role of a supportive adult within the family. I see this all the time. I can set boundaries so that I'm the parent. So, for example, I'll be the one who takes like the authoritative roles of paying attention to the time, making sure that we're scheduled, making sure that we fit in the frame. Oppositely, if I have a client who is more childlike in their regression, not where they need to be developmentally, I can then set boundaries to make sure they pick up their own responsibilities. So like not calling if they're late or missing sessions, not playing into any tantrums. So it really, really depends on who that person is. But a corrective experience is essentially going against whatever's not helpful from that childhood map.
Wow. And that's where taking the time to get to know the client's history as well can be really helpful.
It takes time. Absolutely. Yeah. And it's not necessarily even verbalized.
Right.
It can be later, but in the moment, oftentimes it's just the dynamic. It's invisible.
Right. Right. And again, these invisible dynamics is where we have to be on the lookout for the drama triangles too, especially with personality stuff. But if we're disrupting those reinforcers, like you're saying, like we're going about the map in a different way. We're taking a different route. Like that's disrupting those reinforcers and potentially not kind of going along with the drama triangle. If that's a part of the mapping dynamic.
I think oftentimes it can be. Let's see. So along those lines, then we also have repairing ruptures. So any conflict or potential for conflict in the therapeutic relationship can lead to focusing on the attachment between myself and a client. So for me specifically, I want to validate without judgment because I want a client to be upset. But I need to do that in a way where they also understand I'm not going to abandon them.
Sure.
So sometimes this can look funny. I get excited on my part and I celebrate it. So client might come in and they're like, I'm so mad at you. And I'm like, good. Yes. Awesome. Okay, let's talk about it. Let's get into it. I'm so glad you brought it up. By doing that and going through that process, you can repair the relationship, continue the relationship, take accountability. I need to take accountability for my part, only my part though, and resolve the conflict interpersonally.
Wow.
Yes. So before I go on big bunny trails, because I get so passionate about this stuff, invisible dynamic. What about you?
Sure.
It's another one.
My goodness. So one of the ones that I like to use probably more than anything else is facilitating insight and making connection. So this ideally is client led, especially after some time. And I think Doc Fish, you had a great example that I've heard you use about like teaching a kiddo to like put away their toys.
Kiddos need to learn, right? And adults, we also need to learn. So if we are teaching a kiddo colors, for example, right? Like put the orange ball in the orange bin. Let's put the blue ball in the blue bin. It's not going to be helpful to do it for them.
Right.
It's just not. Like they're not going to learn. You can model for them at first because they have to learn like what the process to do that is. But client-led connections or kiddo-led activity, right? That's so much more powerful and helpful.
Yeah. And that's That's the types of connections that I enjoy making. And of course, we have to model sometimes first, like making those connections. Like, you said this back here, and then you said this over here. Wonder if that means this. Like modeling so that eventually the patient can start coming up with those conceptualizations and those connections as well. But then there's another part of that that's a little different that I use a lot, and it's called immediacy, which is basically calling out the dynamic in the room. So we're naming the elephant. So let's say, for example, Doc Fish, you come into my office. We're talking about something from childhood that's distressing, or something from, it doesn't have to be childhood, it could be yesterday. And you start picking at my couch cushions while you're talking about it. I might use immediacy by saying, Doc Fish, I noticed that when you started talking about this thing that happened yesterday, you started picking apart my couch cushions. What's going on there? And so by naming it, like there's no way we can be 100% self-aware all the time, right? But if we are helping facilitate that self-awareness, like, oh gosh, I didn't even realize I was picking apart your couch cushions. Like we're helping facilitate those insights by calling out the third dimension or the third dynamic in the room that's happening. And that can look like a bunch of different things.
Yeah. I wonder too, I think it could maybe also be directed towards the connection between client and therapist of like, you seem a bit angry with me right now. Okay. So that makes sense. So making connections, facilitating insight includes self-reflection, awareness, looking deep into yourself, and then being able to verbalize it in treatment.
Yeah.
Exactly. And a lot of it can be like how childhood affects your current functioning.
So all of this is part of treatment. This kind of behind the scenes, what's going on? What are we actually doing when we go to work, when we're treating borderline personality disorder? These unspoken dynamics are what you and I, Doc Fish, what we like to focus on as personality disorder specialists, because that's the stuff that's tricky. That like third dimension bird's eye view stuff, the stuff that's unconscious sometimes or attachment based. It's not overt. It's not just what's happening in the room, the dialogue that's being exchanged. It's the underlayers of that. And that in conjunction with the therapeutic relationship is highly impactful for treatment. And those are the approaches that you and I typically take when we're treating BPD.
Yeah. And I love this. I'm so excited about talking about this because it's literally the unspoken stuff.
Exactly.
No one's talking about it.
Exactly. So we learned a lot today. And we learned specifically that BPD is treatable, but you have to put in the work and want to grow. So treatment for BPD is extremely individualized and contains, as we've said, a lot of invisible dynamics. And sometimes this can feel frustrating too for clients because they're not like checking off the boxes like in some manualized treatments, but they're often finding the healing over time without even realizing it. And that's because we target that attachment piece in treatment. The stability then that therapy brings is another big part of the healing process. Because especially with BPD, these individuals, their lives are often so marked with instability that the therapeutic relationship and that therapy hour is like the one thing that's stable. And that is inherently healing. But we also have to be contained and boundaried in order to keep that stable place for patients. All right. So we could talk forever about treatment of BPD and our own approaches, but it is time to wrap up for now. So thank you for joining us today on this episode of The Personality Couch. Make sure to check out our blogs that coincide with each episode for more in-depth information at www.personalitycouch.com. And as always, don't forget to give us a thumbs up or rate and review us on your favorite podcast app. Be well, be kind, and we'll see you next time on The Personality Couch. This podcast is for informational purposes only and does not constitute a professional relationship. If you're in need of professional help, please seek out appropriate resources in your area. Information about clinical trends or diagnoses are discussed in broad and universal terms and do not refer to any specific person or case.